Hello, and welcome to the GoLIVE Health Foundation Health Equity Webinar Series. Thank you to all of the sponsors of the series. Today's episode is brought to you by your friends at NTT Data. We would like to remind you that the Q&A feature is available, so remember to send in your questions for the panel throughout the discussion. And with that, I will turn it over to our moderator, Lisa Esch, who joins us from NTT Data.
Well, welcome everybody. We've got a great crowd here today, and I'm excited to host the next hour with all of you. We have some amazing guests here with us today, and you're going to get some great insight. Here's some things I think hopefully can empower you to make some changes in your organization as well. And as we celebrate National Nurses Week this week, you know, it's interesting to think about what's happening in the nursing profession. They've been on the front lines. They've just been incredibly valuable, as always, but even more so than in the past. And the stress and the strain in this profession has been pretty profound, and it's had a profound impact on all of us in our communities and in our country. And I have a few statistics I wanted to share with all of you today. And it has to do with what's happening with our population. The number of registered nurses needed to provide adequate care for the baby boomer generation has increased from 2.8 million to 3.6 million. The average age of employed RNs has gone from 42.7 to 47.9, with nearly half of all RNs now over the age of 50. And 6 states are expected to experience significant nursing shortages. Alaska has the top vacancy rate of 23%. And we all know that impacts health and well-being, healthcare outcomes, our families, our communities, people that we know. And so those are some daunting numbers. And we also know that organizations in the provider space are struggling to fill open positions. If we think about how we even trained our incoming nurses in the last 2 years, like how different even that experience was and what it's taking now to bring those new grads into an organization and getting them up to speed. You know, everything is different, but we all rely on our nurses. We all depend on it. And healthcare is local. As much as we try to have large systems and large integrated networks, it really still is very, very local. So we've got 3 guests here today, and we're going to do a couple things with our session today. So I'm Lisa Esch, and I should probably introduce myself, and I'm with NTT Data Services, and I lead our industry strategy offering and go-to-market for NTT Data Services. And we work across the healthcare ecosystem for services, advisory, and strategy. And we talk with a lot of our customers who one of their top probably 2 or 3 priorities is always, how do we stop nurse attrition? How do we keep our staff up? How do we keep our people? How do we make them safe? How do we help them with the stress of just what's happened in their lives, balancing kids and parents and work and everything else. So we're going to tackle some of those topics today, and we're going to talk about things that you can do, some mental health things that may help. We're going to talk about technology, and that's a space that I'm pretty familiar with, where technology, we think it might solve a problem, and it actually could create more tension and create more problems. So we're going to tackle some of those conversations today as well. But with that, I'm going to have my guests introduce themselves. So Cinda, would you go ahead and introduce yourself?
So good afternoon, everybody. I am Cinda Rushton. I'm a professor of nursing and bioethics at Johns Hopkins University.
Great, thanks, Cinda. Anna.
Hi, everyone. My name is Anna Dermenchen, and I am the Director of Quality for the Department of Medicine at UCLA Health.
Great. And Becky.
Hi, I'm Becky Fox. I'm the Chief Nursing Informatics Officer at Atrium Health. I'm so glad to be with all of you today.
Great. Well, thanks, everybody. So what we're going to start off doing is each of our guests is just going to spend a few minutes talking about their point of view, their experience, and some of what they want to talk about today, just so you get a background of the different experiences each of these nursing leaders brings to this conversation. And then we'll dive into some of the challenges they've seen. And then we really want to turn the conversation into something about, hope forward. How are we moving forward? How is there hope for the future here? And what can we do to really empower our nurses and make a difference with them, which then makes a difference with patients and health and well-being overall. So Cinda, I'll go back to you.
So, wow, it's a big question. Where are we now? And I think, before the pandemic, we were already worried about the nursing workforce. We had lots of evidence of burnout, and I would say, concerns about the work environment. The pandemic has just exacerbated all of those pre-existing concerns that had to do with staffing, and had to do with having the resources that nurses need to take care of the people that they're committed to serving. So, the pandemic in many ways has highlighted the incredible central role that nurses play in healthcare. And, no longer can we deny that nurses are necessary for this healthcare system to be viable. But at the same time, nurses have borne a very significant burden during the pandemic. And I think what we're seeing is not a lack of resilience or fortitude in nurses. It is the fact that they have been put into a situation that has far exceeded any human's capacity to meet it. And yet we have tried again and again and again with courage and compassion and innovation and what nurses do. But what I'm concerned about is what you might call the long tail of COVID, and what will be the aftermath of having shown up in the midst of crisis in situations where there weren't enough resources, where people had to make really hard decisions that left a kind of moral residue that is really staying with people in ways that are leaving them really wondering about who they are. I think we're having a kind of identity crisis in nursing. Who are we now? And part of that is not captured by the concept of burnout. What we're really seeing here is an erosion of our identity as nurses, but also identity as human beings. So the aftermath of that has been this, in the work that I do, looking at the sort of moral dimensions of that. And we're seeing evidence of moral suffering in the form of moral injury. And in our own research, almost 40% of nurses had clinically significant symptoms of moral injury. That's concerning, because what that represents is really a kind of soul wound that is not going to be easily fixed. It's going to require some real investment to be able to help nurses find their way back to wholeness, and to be able to really figure out, what does this future really look like? Now, on the one hand, that sounds pretty grim, but on the other hand, I think that this is a pivotal moment in our profession, that we pause together and really take stock of who we really are, why we're here, and to claim the fact that we are essential to the delivery of healthcare. That, really and truly, once a diagnosis is made, what people need is nursing care. And that's really what the public ought to be concerned about, is who will care for you if there are no more nurses.
No, I appreciate that. And, you've done some really interesting research around that. So I look forward to, we'll talk a little bit more about that in a few minutes. So thank you, Cinda. Anna, I'll have you go next.
Yes, it's always hard to follow Cinda.
I know.
She's always been a role model for me. And just to give you a background, I started in the critical care unit as a new nurse, and ethics was a big concern of mine. And I read a lot of Cinda's literature and everything she's published. So she's helped me in my professional journey, and I'm excited to be on this panel with you, Cinda. to begin with, I just want to set the stage for me. Going back, it's always been about healthy work environment standards. I did start at a unit that felt chaotic in the critical care unit. So I saw this was pre-pandemic. I got to experience some of the problems that we see in nursing with staffing, with teamwork and communication. And early on, I had many cases with patients where it was the work environment was stretched and it was really stressed. So then it stressed me as a nurse. And I saw how that affected the patient care I provided and the teamwork that developed. And I learned early on that I have to really learn the standards of healthy work environment as an individual, how I could promote it, I could champion it in my own unit. So I learned about skilled communication, and that if I stay quiet and I don't express my views about the patient concerns, then my patient will suffer. So I individually learned how to be more a team-based approach in my own practice. So skilled communication became a big part of my practice. And then I learned about true collaboration, that I really have to think of my team as one unit, and I'm part of that team, and what I do, the work I contribute, will really make a difference. Some of the other standards later on became apparent to me as I became more of an expert in my field, that authentic leadership matters. The manager and how they support the team really affects how people feel if they're part of that work and if they're doing meaningful work. Staffing, there was one night where I was working night shift and I took a patient and I didn't have the support I needed. And we ended up coding this patient, putting them on ECMO, sending them back to surgery. And my heart was broken because I realized if I had enough people around me to help me, that might not have happened. So I've seen the consequences of staffing if we don't have the appropriate number of people on the unit to help. And then some of the decision support, making decisions that are appropriate for people. And the last part that I would say that really impacted me is meaningful recognition. When we have appropriate staffing, we naturally want to recognize our colleagues, recognize the work people are doing. So these standards became part of my practice early on. And every work that I've done since then, I've tried to champion them. And I've seen when the work environment suffers, when we are challenged, the healthy work environments suffer. The standards suffer. So I want to be able to share some of the tools and resources that I've developed through my practice and be able to have a conversation with all of you, hopefully influencing how we can think of going forward.
That's great. And we'll dig into that a little deeper as well. And I want to remind the group as well. So you'll see the Q&A at the bottom of your team screen. If you have any questions for us, I've got that open. I'll be watching the Q&A and I can ask the speakers as well as we go through. So we look forward to getting your Q&A as well. And then Becky, we'll let you go next.
So, I'm very fortunate, there's always a hope that technology will solve all things. So technology will make us all happier. It'll make the patients and the families and the communities happier. The physicians will love it, and we'll have nothing but magical, great outcomes with technology. But the reality is you have to have the right people involved in the whole process of implementing technology and designing technology, and then of course putting it in place. But so absolutely, Cinda and Anna are correct that the pandemic was challenging in so many ways, and it will take us years and decades to analyze what we really went through and how that impacted all of us. But I am very hopeful that because in the pandemic, some other great things did come out. We were able to move some technology through faster. There were some opportunities where we kind of could skip some of the bureaucracy and kind of really focus on the important thing, which is getting access to care, being able to take care of patients, making it easier for folks. And so that is some of the truths that we continue to somewhat hold on to. And I know all of my colleagues around the world hold on to that, of how do we continue to make things easier? So whether that's getting access to patients, whether it's giving data to nurse managers and leaders so they know which staff members that they need to connect with, so they know where they need to focus their efforts, and then helping everyone collaborate together to bring programs together. So, at our organization, Atrium Health, we, like many organizations, have been focusing, how do you support the clinicians at the bedside with the right tools, with the right processes, but also with the right support system, so they do feel safe, so they do feel heard, and so that they feel that they're valued in the work that they do, and that they will be valued in the work that they will continue to do in the future. So I am really hopeful that all these great lessons that we've learned along the way in the pandemic will continue to stick, and more importantly, help us exponentially make a difference in healthcare to not only our clinicians, our patients, our communities, but and then we will continue to have sessions like this where we can share those lessons with everyone and make it easier for everybody.
That's great. And so with that shared lessons, I want to pivot a little bit. And we're getting some great questions in here. I'm going to spend a little more time talking with the team, and then I'll consolidate some of these questions. So we're going to have a lively dialogue here in a few minutes. So when you think about sharing like wins, sharing things that worked, that's sort of like, oh, thinking outside the box, what kind of structural changes in nursing do you think that can really support a healthier, more productive workforce? And Anna, I'm going to have you start with that. What kinds of things have you found? What kinds of things are you thinking about doing structurally that can really help us take on this challenge?
Yes, that's a good question. We sometimes just jump into changing processes to, get to outcomes that we desire. But a lot of it that I've realized in my quality improvement efforts is it's not one individual, it's not even the team, it's like the structures we build that then create these environments for people. Pandemic highlighted a lot about the leadership role. I think leadership always gets the bad rep. They're not around, they're not understanding me from the bedside. And one of the highlights were that we need to build structures where leaders are visible. From my colleagues, everyone I talk to, that's what they value. They want to be heard, they want to be seen by their leaders. And when we build structures where leaders are able to communicate, even if it's bad news, people understand during this time, but they want to hear from their leaders. So through town hall meetings, building a newsletter that goes out regularly, a lot of my leaders walk through the units, and the nurses know that they're going to be seeing their CNO or CEO walking through the hospital and checking in on them. The town hall meetings have been so important, especially when it's recorded and it could be disseminated for others to hear, because a lot of the concerns come up and then the response is no one's doing anything about it. And a lot of times from the bedside, we don't understand the leadership structural issues that that exist and that people are thinking it through and building systems. So thinking from the unit level, a lot of things that have worked in the environment that I'm at is empowering the bedside to have a voice. So staff nurses creating their own councils. There are already structures like the unit practice council, but some areas have created a social council where they plan events or things that are friendly during the COVID pandemic. It existed before COVID, but now thinking through what would be appropriate during the environment like this, and creating an environment where nurses are able to connect peer to peer, have support. If there are any kind of trouble, they know that they can rely on their colleagues. I think at the unit level, I've seen a lot of those types of best practices develop through various councils, and you could call it, resiliency council, whatever it takes, I think, for nurses to feel that they own their own practice and they own their own unit outcomes, and then bring that to a larger governance group of how we can create even wider structures in the health system to support nurses to have the time off to attend these meetings, to get the support they need. I think a lot of times we talk about wellness, we create all these wellness programs, but we don't realize we don't give the time for them to do the activities and enjoy it. And then we don't have any place in the hospital for them to have that corner of 5 minutes. So a lot of the areas that I know, they've created Zen Zen like chapels or Zen gardens where nurses can take 5 to 10 minutes during their break to be there and really rejuvenate and energize before going back to work. Some of the other system changes I think we can do, we can really look at our policies and procedures and see what are the barriers for practice and consider like taking work away. We always keep adding work and we don't consider like stopping some things that are not evidence-based. So those are some things we can do.
That's great. Becky, any other thoughts, or Cinda comments?
I think, Anna hit it right on the head. There's things that we can already go ahead and put in place. We at Atrium Health, we put a Code Lavender program in place. So Code Lavender is something that you can literally call and ask for team support. It's led by our pastoral care. We piloted this out and then of course rolled it out through the pandemic. Some of our facilities have done just that, created a Zen place so that staff can go and have a few moments to rejuvenate, to feel connected, supported, and to take a break from the stressful environment they're in. And then what I'm really excited about is we have a facility leader. She's a nurse, yay. We have a nurse who helps design what our units look like today and into the future. And so one of the things that they've really been mindful about is how do we create a space so that any of our staffs, not just nursing, but any of our staff can have a place to go and take a break and take a moment. So whether it's a peace garden outside the doors, even the space, even where the meeting rooms, making sure that there's windows and light. These are the things that really breathe energy back into our staff. And so we're very focused on trying to continue and learn from others as to how we can even do that better.
That's great.
So Lisa, I would just add one thing. I
Please
think,
do.
Anna has really hit it on the head about we struggled during the pandemic of creating all these great things, but then nobody took advantage of them. And so I think we have to step back and ask ourselves, what would it take for staff to take advantage? And I think what Anna's pointing to is we have to have space, and we cannot staff at this razor thin margin and expect people to be able to have flexibility and to take advantage of pausing, which everybody needs in the midst of this to restore themselves. So that's kind of a different mindset of how we think about staffing and how we think about our resource allocation. The other thing I would say is, especially, it was true before COVID, there were ethical issues that were more episodic. But what COVID created was unrelenting ethical questions for people to deal with. Every single day was a resource allocation struggle. And so having regular spaces where people can pause together and process what has happened, and to have rituals and practices that help people let go of what they've carried all day so that they can leave work with a little less burden, and to be able to see that time as, renewal time. One of the things that we do not have in our healthcare system is that flexibility. So when you're in the military and you go into theater, you have a designated period of time that you serve, and then you have a period of recovery. In the pandemic, there was no period of recovery for nurses or other healthcare professionals. And so thinking about how do we do the staffing process in a way that doesn't keep going back to the same people saying, can you come in, when in fact, people need that recovery time to be able to fulfill their assignment. And so that's an example of a mindset shift, that I think is really important to think about as we're designing for the future.
Yeah, and what a challenge that's going to be, given the fact that we don't have enough staff to staff what we need, let alone to staff that gap that we need for people transitioning off shift. Those are some big challenges for sure. We're getting some great questions here. I'm actually going to pivot over to the questions. So with that, I said, hello, I'm an ER nurse that worked through the pandemic. Most days of the week, I think about leaving the profession. What can we do as nurses on a day-to-day basis to help guide ourselves back to wanting to stay in this field? Wow.
I
Wants to
could,
start?
yes, I could go first. Thank you so much for your honest question. I've stayed part of my little chapter organizations at, in my community. So the critical care nurses chapter that I started when I was a bedside nurse, I've been part of it now, more of a leader role. And I talk to nurses at the bedside on our monthly meetings. So I know the challenges at the bedside. And some of the things I asked them for some feedback, some of the ways that they stay engaged, and I want to pass that on to you. They find things like their meditation apps in the morning before they go into the unit. Some of them really journal about and find, like, if they've received notes from patients, they put it in a box and reflect, take that out. If you've ever received anything from a patient or a family, they read those to remind them why they're in the profession, the reason they went into it. A lot of them are faith-based. They use their faith. They have these practices that they continue that help them feel nourished and rejuvenated, the exercising. I mean, I asked them, I have a lot of app recommendations that I could put in the chat that they use internally that the health system has provided, as well as some external ones that are free. I think what I found to be the best approach is, like, if you can have a peer group within your local, even outside of your hospital, where you feel like you can connect, vent, and share your frustration, and have like-minded people understand and validate your feelings. So then you're in this community of nurses, exceptional nurses, who are trying to do the best they can during this tough time. I think having that validation and the opportunity to share carries you through until you feel like you're well enough. But I also recommend counseling, therapy. A lot of people are seeking therapy. They're doing things that they need to personally take care of themselves, not working extra shifts, sleeping enough, making sure those basic needs are met.
Thank you.
Yeah. Can I just add one thing to that?
Yes.
I think we are so good at extending compassion to others. We really need to extend it to our own limitations. And instead of seeing ourselves as failing, to see that we are doing the best we can with the resources that we have. And part of that is extending some grace to ourselves, and really investing in self-stewardship, that I have to know myself and my limits, and I have to be able to turn toward those limits without judgment. And I think that's the part, our perfectionism kind of shows up, or I've heard nurses say, well, I should be doing more. And I'm like, oh my gosh, how could you possibly be doing anything more? So some of it is actually being a little more generous toward ourselves, and finding ways. I think we are a group that tends to be overly responsible. So asking, what part of this is really mine and am I responsible for? And having some ways to let go of the expectations that you somehow are going to fix these unfixable problems, or that you're going to solve, the pandemic, which you didn't create and you can't fix alone. None of us can. So it's part of that, of also considering, for you right now, this moment, sometimes we do need to make changes in our work environment. Sometimes we need to find different ways to serve. My hope is that if that's true, that nurses find another place where their gifts and talents can be used instead of leaving the profession, because I do think it's a time where we've got to also support each person to make their own decision about what is right for them, and welcome everybody to be in our profession in whatever way they can.
That's great. And I think there's, we're seeing more options for nurses that need to take a break from the intensity of inpatient. Organizations are creating other places that they can work. And it decompresses them a while. They may do it 6 months or a year, and then they're actually ready to go back. And so I think organizations are figuring out ways to keep their staff in different roles still doing nursing, and we're having nurses do different things as well. So I think that's definitely creative. I want to switch. We're getting lots of questions about technology. So I'm going to ask Becky this question. So if we think about how rapid technology was just like drop bombed into the provider setting, with all the technology we were using to try to connect families, do things remotely, and obviously you're not doing nursing bedside remotely, but there's a lot more technology today than there was a couple years ago. And it's been a mixed bag. And most people believe the impact that it's had on patient care. Part of it is because when technology enters the room, it becomes more impersonal. So there's this, the nurse stands at the computer, they're asking questions, the patient might be behind, there's this whole impersonal experience that can happen with new processes and new technology. But also, if it works right, it can create a lot of value and insight that helps the nurse actually personally connect in a way that they weren't able to before. So there's really two sides to what technology can do. Share your thoughts, Becky, on the impact technology's had. We can focus on the good. We've all experienced the bad, so we're not going to talk about that. But let's talk about the good in the future and what things maybe we can do to help with nurse retention, with the reconnection. Yesterday when we were talking, I'll stop in a minute and let you answer the question. But one of the things that you all just affirmed is how nurses, the human connection is what gets them through the stress. There's human connection, helping others, and for the nurses on here, what I'm talking about. There's just that human connection that happens that recharges you, that creates that, I can do this more. This is why I'm here. This is why I became a nurse. So talk a little bit about that and the impact technology has on that.
Yeah, so you're right. So I think even outside the realm of nurses, everyone likes to connect. We're social creatures. And so we knew in the pandemic when visitation was cut, you couldn't have families at the bedside. That was a huge thing. Plus you're living in isolation at home, so the isolation, being able to connect with people was an important thing. Nurses help support that. So if I have a patient in the hospital and I'm the nurse caring for them, and I know how important it is for them to connect with their loved one, we want to help support that. So, we were fortunate to learn from some other great organizations. So when, and I'm an ER nurse, shout out to the ER nurses out there by background, but we read an article that a nurse had in the emergency department had used baby monitors. So somewhat simple technology, we always look for kind of much more complex technology to put in place, but baby monitors were a way to look into patients' room, conserve PPE, be able to connect patients. And so, we saw this article. Next thing you know, I've got a team of clinical informatics that's, shopping at Kohl's and Target and trying to, because you couldn't buy things, because the supply chain was shut down. And so it was amazing how we actually put a baby monitor program in place in less than 48 hours, which was incredible. We had great support from our foundation to help support that financially. And then we were able to put it in place. And what I love though, is we took a box of baby monitors up to a nursing unit, and the nurses on the unit, being entrepreneurs and innovators in and of themselves, said, oh my gosh, we need 2 of these. They grabbed them. They had 2 patients, one that they were both married. They had not been apart in several decades, and they were admitted separately on the unit with COVID. They put one baby monitor in one room, another baby monitor in another room, and now these 2 patients could connect and see each other. So it's that kind of stuff of it. It can be very simple technology. You let nurses be very innovative, as they have been for 200 years. And that's how we're able to help support them in connecting to patients. There was lots of other organizations around the world that helped establish hospital at home programs where we can keep the patient at home, check on them with video links, and really bring the healthcare to them. If they get into trouble, we have chat bots, we have ways to connect with them. So even though some of these things, I know in the IT world, that's hard stuff to set up and make sure it works smoothly. But when it works great for the families, for the patients. another program that we worked, we talked a little bit about, sometimes nurses do need to, if you've worked in a tough space and it's mentally draining on you, maybe there's another location you can work out still within your healthcare organization. And one of the programs we set up was a virtual nurse, we called it the Family Connection Program. So we had an empty office building. We set up video monitors in the building, and then we had video cameras already in our ICU critical care space. And like I said, all of our nurses want to connect the patients with families. But what we were able to do, literally with some command strip duct tape, we were able to set up in a very private place. We had nurses that couldn't be at the bedside. Perhaps they were immunocompromised or, couldn't be directly in doing bedside care. And so they worked in these office spaces. They would reach out, connect with families, and then connect those families to be able to see into their loved ones and into their patient's room. And, at first we thought, okay, this will just be great for a visit or two, but and I'll try not to get choked up, but when you hear families talking and praying over their families that couldn't travel, that were from other countries, singing in different languages. I mean, you could walk down our office building and you could hear room to room, different languages and dialects and music playing and prayers. And sometimes there were happy situations and sometimes they were really sad, but all of it was very meaningful. And most importantly, it allowed the nursing staff in the critical care to still feel supported, because they knew how important that connection was. And so they felt that our technology was doing the right thing. And then even to hear from, the immunocompromised nursing staff who said, man, I feel like I couldn't do anything in the pandemic because I was of my own personal situation, but they felt like that it was some of the most important work they'd ever done by connecting patients and families. So that I get really excited about that. If there's ways, to figure out whether it's taking duct tape or baby monitors or very important servers, networks, and entire virtual platforms and making them work, that's what we really need to do and champion in the future to make our teammates feel supported, our patients and families feel connected, and then, we all can reap the benefits of that.
That is great. Wow. Well, I've got a couple more things I want to mention here. A couple people have mentioned this, and so there are questions about mental well-being, and I'm not going to get to all of them, but I want to actually, there's a link in the chat, I believe, and it's called Emotional PPE. And it's a nonprofit that provides free confidential therapy to healthcare workers. And they're at emotionalppe.org. And so that's in your chat, and that's a great resource for people. I want to then, Becky, that was a really great perspective. And again, just the creativeness that people have on tech and how that just release the burden off of the bedside nurse to really focus on those things and not carry the guilt of trying to do all those other things that needed to happen to support that patient. So I think that's fabulous. I want to pivot to a new question from the audience. And this is, what can we do as leaders to address the new reality shock that our staff are experiencing with regards to workplace violence? Who wants to speak to the workplace violence first? Cinda?
Well,
I'll let you go first.
Yeah, gosh, this is a really hard one, because I think, as we've heard here, nurses get their fuel from their patients. And when your patients turn against you and are treating you in disrespectful and violent ways, it's like the last cut. It's just so difficult, to continue to work in environments that don't feel safe. So one of the things that I had the privilege of doing during COVID was working with the Barrel Institute and a group of chief nursing officers to try to think about how do we create an ethical framework that balances staff safety with patient experience. And so we created 7 ethical precepts, and part of that process was to give us some grounding for, as we're designing, how do we uphold the value of respect for every human being. That means the people delivering care and the people receiving care. How do we create environments where it is possible for nurses to be able to be safe in their work environment. And what we discovered was that the core issue was really around trust. So trust with ourselves, trust with the people that we're serving, our colleagues, our organizations, and our leaders. And so what nurses need, I think, at this point is, number one, they need to have the tools and resources to respond to these instances when disrespect and violence occurs. They need to feel that they are capable and prepared to deal with those realities. But in addition to that, I think we also have to think about, how do we create new norms of respectful engagement that are bidirectional? Because in the pandemic, I think again and again, there's the assumption that nurses are going to be there no matter what. And what we are seeing is that there are limits to nurses' abilities to continue to work in environments where these kinds of circumstances are present. So part of it is recalibrating the social contract with society about what it means to receive and give care, and that there's a bidirectional responsibility for creating the environment for healing. So I think this is an issue that we've got to think differently. It can't just be call security. It can't just be, these more transactional kinds of responses. I think we've got to step back and really ask the bigger question. And how do we, in the midst of this, begin to create a new paradigm for patient and nurse and healthcare professional engagement?
Well, go ahead.
Sorry, I was going to add more, Lisa, if that's okay. I totally agree, Cinda. And I think one of the ways we could do that is have contracts with patients. A lot of times, like, patients don't understand that it's a no violence zone. You're in a hospital, we tolerate zero violence, verbal and physical. A lot of times we find that physical violence exists because patients think that it's their loved one. I mean, there's just a lot of high emotion, and it's a challenging time for many of our patients. But if we create that environment and build structural things within the hospital, like making sure that there are panic buttons, nurses know where they can go for safety, like getting help from their teammates. It might be security, but it could also be a therapist, psychologist. And if they think the family's struggling, they get like C-suite people involved right away. That needs to exist in the guideline, and nurses need training for de-escalation techniques. All of these things are important. I have written a lot about this, but one thing I would say that the literature lacks is when the nurses are in this situation, they face the violent incident. A lot of health organizations don't have a structure in place to support that nurse. There are no secondary or tertiary support systems. And that's what we need to think about. Prevention is the most important thing in violent situations, but we need to build these types of structures where the nurse might need physical therapy, emotional therapy, all kinds of efforts to get better and recuperate before they can come back into the workforce. And that's lacking, which is sad to see. So we need to do more in that effort.
It's a trauma when that occurs, and we need to really see it as a trauma that requires intervention. It can't just be go back to work now. These are for many people, these are lifelong residues that they carry. And I feel like we as a community of nurses as well, we need to also shift the culture that asking for help is not a sign of weakness or failure. We need to recalibrate our own culture that supports people. There shouldn't be shame associated for asking for help, that we should, as you said, Anna, so beautifully earlier, everybody needs therapy at this point, and we should try to figure out how do we remove the impediments to access and make it possible for people to get those resources without having to do some heroic thing to get them, that it's just part of the process, as you were saying.
Yeah, can I highlight CHLA actually has an employee assistance program on site for nurses to like ask for these resources if they need it. So thinking through like how we can build this within the organization where you don't have to call multiple numbers to get help. You could go right there and get the resource you need.
Yeah, and we're, this violence that we're seeing with healthcare providers, I mean, we're seeing it in all aspects of society right now, just really irrational, violent reactions. And it's just it's a challenge no matter what industry you're in. But I think it's really, when you look at what the nurse at the bedside, the risk, the stress that they've been under, and the triggers people have for whatever reason, it is challenging. But I think you nailed it when you said there cannot be a stigma for seeking help. And it's almost like, do you just have mandatory, like a process that happens to make sure that you can help that person heal from that injury? The mental piece of it. It is the trauma, probably even more so than maybe something that happened physically. Safety is a big deal.
I think the other thing too is really, sorry, just to add, it's really focusing on prevention and identification earlier too. So we do need to continue to use, there's tools that we can put in place. So that's all I just say is we definitely have to support the clinicians after something happens. Yes. And then more importantly, almost have to exponentially focus on how do we prevent these things from happening and recognize that it's happening across the United States and around the world. This is feedback from the public. I would say there's probably some efforts that need to be made in the public health space, mental health space, to help everyone all get to a better way of handling situations.
You got it. It's eking over. All right, we're going to pivot to another question we're going to come back to the staffing tension, being understaffed and organizations' mandates. So the question is, resilience and efficiency are opposing forces, and the understaffing challenge in nursing and many other fields is clearly the result of erring on the side of cost control. How much of the nursing shortage is the result of the pandemic versus how much of it is generally staffing for good times resulting in shortages in tougher times? And then I have a follow-up question that's going to say, how do we reduce the nursing wait list for 2 years to get more nurses into the pipeline? So that'll be my follow-up question. But anyway, let's talk about that first one. Who wants to tackle the staffing?
Well, I'm going to start, and then I know everybody else has something else to say about it. So this is not a new conversation. No. We've been having this conversation for decades. And we keep having the same conversation. So I think one of the opportunities is, how do we shift from this tired conversation about supply and demand and how we look at the budget? I would say the budget is the most important ethical document in an organization. And what we invest in is what we care about. So if you think about it in that way, our mindset has been that nursing takes up the biggest portion of the budget, and therefore it's a problem that needs to be reduced. I would say part of our pivot is to not see it as a problem, but to see it as evidence of the important role that nurses play in this healthcare system. And therefore, we ought to invest in it so that it is healthy and everyone can serve in the way that they're meant to. It's the scarcity mindset that I think has contributed to this kind of razor thin staffing that is fueled by capitalism. So we've got to, we got to take responsibility for the fact that that's a bigger question. In terms of the supply side, I prepare nurses to be in the workforce. What is so discouraging is to see the statistics about how many new nurses leave after 1 year. We are engaged in a project here in Maryland, the Resilient Nurses Initiative, to begin to prepare nurses to meet the challenges that they find in practice, starting from the first day of nursing school. We're working with faculty to engage them in how they can authentically, sort of prepare and demonstrate what it means to be good stewards of our own resources. And so I think we've got to think also, to Anna's point, we cannot only focus on the supply side. We've got to ask ourselves, what are the systems and structures that are needed in our practice environments that keep nurses in those environments? And the healthy work environment standards are one piece. But I think we've got to really shift our mindset. We can't just pretend nothing happened during this pandemic. We need to really say, what is the new paradigm for the future? And how do we design it?
Great.
Can I add something?
Yes.
There was a comment about quality being affected, and it's so true. I mean, we know that when staffing is short, patient pay the results of it, they have poor outcomes, their length of stay is longer, mortality rates go up. There's so much literature out there about nurse staffing, even before the pandemic. But during the pandemic, we've noticed so many drops in quality and preventative care measures in our outpatient population, our inpatient population. CAUTI rates have gone up. All these adverse events have gone up in the hospital. So we know it's directly impacted our work environment. I think staffing, we think it's either has to be this way or that way. Instead, we can approach it in a very multimodal approach, where a lot of people are leaving the profession because they don't have flexibility. They feel stuck.
Right.
They have to show up over time. They're forced to, work certain days and hours. The organizations that are retaining their staff have flexible models. A lot of the units that I know have incorporated, like if nurses are wanting to retire, but they can stay 40% of the time, they become the nurses who come and do break for other nurses. There's one unit who has a quality person, basically it's an experienced nurse who gives breaks for other nurses. And during that time, he checks drips, he checks if dressings have been changed. It's like a quality check, and then gives feedback to the nurse who is the primary nurse. I think we have to think of models of where we can retain our nurses in different, whatever they're capable of giving, and then really help shape like the staffing in the unit and support people at the bedside.
Yeah, Anna's exactly right. We have to look at different ways of doing this, the things that we've always done. One of the things that, again, we borrowed from another organization was doing virtual nursing observation. This isn't watching the patient, but helping to support the nurse. So we're actually looking at what do we do with our next cohort of nursing graduates who may have had a different experience in this pandemic than, the nursing program that we all went through. And so how can we put, cohort all of these new grads together, provide nursing support virtually, and really help make them feel supported in the process, so that after a year they don't want to leave the profession. I think we all recognize that's the challenge, and unfortunately, I would love to say there's a lot of master's prepared, doctoral prepared nurses at home that are ready to jump into nursing school and help support that. I'm confident any one of us would take a cloning machine if that could help, but that's not in place right now. And so what we really have got to do is help support nurses where they are, support them in their education, and really make sure that everyone feels that there's different options. There are 1,000 ways you can go and be a nurse. You don't have to be miserable in what you're doing. You definitely can find how to channel and appreciate what drew you to the profession, what love you have, and what makes you happy in it. And I'm confident there are many organizations that will help you find the right place to be in.
That's great. And, I was talking with some nurses at a health system in Nashville, almost a couple of months ago. And we were talking about the work at home or the hospital at home and like, how are you going to staff that? And they're like, oh, that is the easiest thing for us to staff at all. Because she said, I was shocked. She says, how we're retaining our nurses, the ones that are so burnt out on the floor, we allow them to do like the shift that works for them. So they may do a 9 to 3, a 9 to 12, they'll take them in for the however many hours they'll give them, and they deploy them into that element, and they're retaining staff. They have no trouble staffing that. And I'm like, wow, that's innovative. And then they do that for a while, and then they're ready to maybe go back or not. They're doing that because of their kids and life and all that, but it's really a good option. Well, we're going to wrap up here. I have one more note I'm going to share, and you all will love this. This is from Sean. Thank you, Sean. I just want to share my love and appreciation for you and all you do. Great session that resonates deeply. So we're getting some wonderful comments in here. And unfortunately, we just cannot answer all those questions. And we actually had a pretty scripted dialogue, but when I saw the questions coming in, thank you, group. I pivoted to just having conversation with the questions, which I think was really relevant. Anna, Cinda, Becky, thank you so much for the time today and just your contribution to healthcare and to nursing, your leadership, your vision, and thank you for communicating that with us today and sharing your experiences with us. And to the group, we had a pretty big group here for most of the session today. I know people are dropping off, but I just want to thank everybody. And
Lisa, can I invite everybody to our Nurse Antigone? Please join us for this groundbreaking performances that has a nurse chorus to use the Greek tragedy of Antigone for nurses to talk about their experience. It's been profound. And we're going to be doing 12 performances. So please join us. It's been a really incredible. So join.
Well, thank you so much. And also we've got links for resources I think in the meeting invitation or the site where that's at. And I think it also went into chat. So Anna and Becky, Cinda, thank you so much.
Thank you to Lisa and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.